between operative and non-operative. We've gone back and forth in trying to select which one is going to give us the superior outcomes. And we always discuss things, treatments as being relatively equal, but in the trauma world, it's difficult to really emphasize where the outcomes should be prioritized. And I know in sports, Dr. Khan, your experience with trying to get athletes back on the field, people back to sport and activity. What do you think we need to emphasize early outcomes more to really get at what the difference in superiority may be?
Yeah, I think earlier outcomes really are very important, but also, it really depends on the patient, I think. When you look at the 1-year outcomes, if they're similar, I think that has a lot of weight as well. So, yeah, I mean, it's an interesting question. How do you decide, Herman, in your clinical practice, who you're going to be fixing versus not fixing if you have a good reduction?
Well, I think, it starts the discussion with the patient for me, really. And I'm happy to treat these operatively or non-operatively, depending on what the patient's goals are and whether they're trying to get back to work or get function of that wrist earlier. I may try to discuss the advantages of getting out of a splint or a cast before the 6-week period you would be if we're treating something non-operatively. If a patient's really not trying to get those early outcomes, then oftentimes I'll work with them to go through non-operative management and get them to the 1-year mark, where they'll settle out the same. And I just noticed we have a hand up from Sam Mahmood here, so I welcome you to jump in with your thoughts or questions.
Thanks, Dr. Khan and Dr. Johal. It's a great discussion. In terms of the second paper on the distal radius fractures, I think there's plenty of evidence out there in operative versus non-operative, as you just mentioned now. In my practice, it was operative versus non-operative. If it's going to be operative, it's going to be the volar plate fixation. I was asking if you in your practice have ever had to use an external fixator, except if like maybe a temporary measure intraoperative just to bring it back to length and then maybe take it off for closed, even comminuted fractures. Because I think that debate has just blew my mind away, that I would never use Exfix as a definitive fixation for a distal radius fracture. So I would like to know what would be your take on this.
Yeah, I think the discussion around Exfix and distal radius is it's an interesting one to have, and it's especially seeing over the last few years how clinical practice has gone. I think the discussion around an Exfix becomes less and less relevant to treatment options. And in my training, I trained as using an Exfix as a temporary device in the OR to help achieve a reduction that you'd subsequently maintain with a plate placed volarly or even dorsally or both sometimes. Throughout my fellowship, I was exposed to the use of an Exfix both intra-op and then subsequently post-op, with the benefit or the advantage being you've already placed this Exfix, you've already used the bars, you've already got the pins. Now you can potentially avoid a cast in that patient or a splint for a couple of weeks or 4 weeks, and then subsequently remove that Exfix in clinic. I saw that practice pattern a little bit through fellowship, but then soon thereafter, I saw the internal Exfix, so to speak, or the LCDCP, the dorsally placed LCDCP that spans the wrist spanning plate. And ever since that sort of came into practice in my hands, and I think in the hands of a lot of my colleagues in Canadian orthopedic and I think North American orthopedic trauma, I'm seeing the application of that a lot more frequently as an option to definitively manage some of these complex wrist injuries. And subsequently, that's removed with a whole, with a secondary procedure, although you can do that under local in some offices too. So I've seen Exfixes, I think, used some through my training, and then I've really seen them disappear, I think, in clinical practice outside of temporary intraoperative use. It'd be interesting to hear anybody else's experience, say, along that line, or even, talking now about the third paper where they talk about the use of an Exfix in comparison to ORIF. Is anybody still using Exfixes for management, definitive management for these types of fractures? It'd be interesting to hear thoughts. Whereas, I think a lot of people potentially have transitioned to internal dorsal plating, temporary or definitive. Any of these adjuncts, how have they been applied? How have you found them in your practice? It'd be interesting to hear thoughts along those lines. I see. Sorry, not, or we can jump to the first paper and maybe chat a little bit about the proximal radius, the radial head fractures. Again, we get into a discussion around operative versus non-operative. And as we sort of discussed earlier, for distal radius fractures, that pendulum swinging back and forth depending on where your outcomes are prioritized. But say for these injuries around the elbow, I'm not sure we're seeing the same or even early benefit in operative management for these. And, it's elbow stiffness is always a concern. And I think maybe Moin, you might be seeing some of these patients secondarily. Do you see a lot of post-traumatic stiffness around the elbow or say around these types of injuries or maybe other benign injuries around the elbow?
I haven't seen too much actually in terms of stiffness around the elbow. And I personally am maybe more conservative with treating these minimally displaced proximal radius fractures, radial head fractures. I don't know what has your experience been?
Yeah, I think similar. If it's not a block to motion in the acute assessment, then I'm less aggressive. If there's any sign or hint that it's going to be have a functional impact for that patient even early on, I may offer, or if with either headless compression screws or something that's not too prominent in that area. But again, it depends on the goals of the patient, and I think that we see that theme come up time and time again. And it is hard to hang your hat on it. It's a study of not too many patients, but then it just is part of the overall discussion on evidence for these patients as we see them in the clinic. And seeing a comment here, anybody in either Dr. Khan or anybody else in the group have experience treating radial head fractures arthroscopically? Have you ever done an elbow scope and tried to see at least the displacement or guide your fixation, or is that again getting a little too aggressive for you?
Yeah, I mean, I haven't. I think you could probably get pretty reasonable visualization though. But yeah, I have never seen that.
Yeah, I think it's as scopes become, I think, more accessible and potentially is something that's not as cumbersome to bring out in the OR or even in some clinic settings. I think people may discuss this a lot more as an adjunct for either simple or even complex periarticular trauma. So it would be interesting to hear if anybody's used a scope, maybe even in the wrist for distal radius fractures. I think you might hear about it a little more frequently, but either in the elbow or the wrist, has anybody had experience with scoping for trauma? Maybe not. I don't see any hands out there. So, maybe something that's on the horizon. I think we're going to hear about it a lot more frequently as some of these minimally invasive techniques get better and better and less of a hurdle to integrate into treatment. So if there's no other questions or comments on sort of the first half, I'm happy to move on to the next part. And if any questions pop up as we're discussing these, feel free to type them into the chat and we'll try to keep an eye on that and integrate into our discussion here. But jumping into humerus fractures and talking about debates around fixation option, we have an RCT here looking at locking compression plate fixation versus intramedullary nail fixation for humeral shaft fractures. So jumping right into treatment options and comparing one to the other. These authors set out to look at displaced humeral shaft fractures and comparing either locking, intramedullary, locking nails as well as lock plate fixation. And compared the two arms with respect to radiographic as well as clinical outcomes up to 2 years following management. They had 63 patients total. So again, not a big study, but it's a well done study where they had 33 patients in the locked compression plate arm, as well as 30 patients in the re-intramedullary nail arm, and compared radiographic and functional outcomes. And really, you know, they found that the two arms weren't statistically significantly different with respect to callus formation up to two years full follow-up. And they couldn't really find any statistically significant differences with respect to the incident of complication, radial nerve injury, which is always interesting to discuss around humeral shaft fractures, reoperation or need for reoperation with respect to non-union. And then they couldn't really find any major differences with respect to any of these functional outcomes with bifracture pattern that was sustained throughout the 2-year period. And again, graphically here, we can kind of go through all the different outcomes that they looked at. They did find a slightly improved score for the UCLA shoulder scale. Sorry, there. The UCLA shoulder scale benefiting in favor of locked compression plating. And you know, in terms of pain, there was slightly lower pain, which is actually surprising. And I think a lot of the discussion for these two treatment arms has traditionally been around the shoulder pain. And so, you know, potentially less shoulder pain for the locked compression plate arm as well. But I think, you know, there's a lot of other papers that contribute to this discussion. And if you go to oe.com, you'll see that there's an up-to-date meta-analysis of looking at this exact question and breaking it down by site and the humerus. So I just wanted to bring this to discussion as well. And we look at, you know, the proximal humerus. We can't really find a difference between the two treatment arms with respect to rate of union, as well as need for reoperation or adverse events. But again, we're limited by small sample size as we sort of are plagued by an orthopedic trauma RCTs. When we get down to the shaft, we look at, again, there's no real difference in rates of union or need for reoperation between the two groups. And again, small sample sizes sort of limit the extent of our conclusions, but we can't really find a meaningful difference between these two treatment options for this. Now, I just wanted to bring this to discussion as well, and this is, you know, hot off the podium of this past week's OTA, where we had the Canadian Orthopedic Trauma Society present a randomized controlled trial comparing operative and non-operative treatment of humeral shaft fractures. And I think this kind of highlights why this discussion is important to have, because, you know, this is a well-done RCT that was presented comparing patients with displaced humeral shaft fractures that were amenable to treatment without a non-operative bracing or operative fixation. All the patients that were in the operative arm of this study had locked compression plating, and they compared these patients up to 2 years, looking at functional and clinical and radiographic outcomes. And they had 173 patients, so actually a large study, especially in comparison to the ones we just discussed. And they had 86 patients treated non-operatively and 87 treated with ORIF. And they found there wasn't any difference between the groups, but they did find a difference with respect to the clinical and radiographic outcomes, where these patients who were treated operatively did have an earlier improvement in their functional outcomes that did sort of equalize throughout the 1-year period. And then radiographically, they also had improved scores as well as decreased need for reoperation. And an important discussion around this study is the patients who didn't initially have surgery and subsequently required surgery within that 1 year contributed to, I think, a leveling out of these outcomes. So potentially a real benefit in fixing these patients early. And I think, you know, as we just discuss how we're going to fix them, we can discuss plating versus nailing as part of that, as part of where I think this is going to be going in the future. But certainly exciting, as this is the best level evidence around this is we're going to see, and as good as we're going to see. And it's always nice to have it from the Canadian Orthopedic Trauma Society. So moving forward, we'll hear a little bit more proximal humerus from Dr. Khan.
Yeah, so this is another study that was published in JSES comparing deltopectoral versus deltoid split approaches in plate fixation of proximal humerus fractures. It's a randomized control study published in 2020. And the main question was, in patients undergoing locked plate fixation in the proximal humerus fracture, how does a deltoid split approach compare to the classic deltopectoral approach with regards to functional outcomes, postoperative complications, and scar satisfaction up to 26 months postoperatively? And so these were 85 patients for a total sample size. They were patients that were aged 18 years or older with a displaced proximal humerus fracture. 44 were randomized to a deltoid split approach, and 41 were randomized to a deltopectoral approach. We can skip this one. So what were the important findings? And I think that this quote doesn't necessarily compromise everything that the study found. So we'll go over this and add a little bit more to it as well. So the results revealed that there were no statistical differences with regards to cutout of the screws, non-union, fixation failure, reduction loss, or AVN, HO, or reoperation between the deltopectoral group or the deltoid split group. And initial fixation was similar between the two groups. The additional points that we wanted to mention about this were that actually all the clinical outcome scores that were obtained in this study were actually in favor of the deltopectoral approach. So the Q-, the SF-12 were better in the deltopectoral group. And there were actually more complications in the deltoid split group, but they didn't reach statistical significance. So so these are the breakdown graphically. So the deltoid split on the left and the deltopectoral approach on the right. Operative time really is similar between the two. Blood loss decreased in the deltoid split group. Pain decreased in the deltopectoral group. And then again, these functional outcome scores, lower is better, favoring the deltopectoral approach. Again, these are more functional outcomes, so SF-12, similar findings. And back to you, Herm.
Sorry, just a jumpy computer screen there. So just getting to the last the studies to discuss around the proximal and distal humerus. We're talking about the distal end now, and we're looking at a study that compared elbow function between lock plating and non-lock plating for distal humerus fractures. Again, another RCT looking to compare these two treatment options for distal humerus fractures to see which one would yield better elbow function with respect to their outcomes. And they had 60 patients total, with 30 who were randomized to the lock plate group and another 30 who were randomized to the non-lock plate group. And they compared these patients with respect to the Mayo Elbow Performance Scale, as well as clinical outcomes with range of motion and flexion extension, and looking to look at important differences. In comparing the two groups, they found that the incidence of union at 3 and 6 months was not statistically significantly different between two groups. And furthermore, with respect to range of motion at these early time points of 3 and 6 months follow-up, there was no statistically significant difference. However, as they got further on in their follow-up, they did find that there were 2 cases of non-union with 2 and 4 patients in the locked and non-locked groups respectively, as well as 2 cases of infection that were observed in the non-locked group, and HO, there's 2 cases in each of the groups. But also of importance is as they looked at those outcomes further on, they did find that there was some superiority with the functional outcomes at 1 year with the Mayo Elbow Performance Scale score favoring the locked plate group in comparison to the non-locked plate group. So an advantage there with that outcome. And I think, sorry, back to Moin for the final paper in this session.
All right, so this is also a really hot topic, paper presented at the OTA 2020, looking at reverse shoulder arthroplasty for proximal humeral fractures in the elderly. So this is another randomized multi-center controlled trial looking at 2-year outcomes. So the main question was, in patients with displaced proximal humeral fractures, how does reverse shoulder arthroplasty compare to plate fixation at clinical outcomes up to 2 years? And so what were the study characteristics? So this was 124 patients that were aged 65 to 85, and they were recruited between 2013 and 2017, and these had displaced proximal humeral fractures. The intervention was a reverse shoulder arthroplasty in one group, and the control was patients received plate fixation, so around 60 patients in each group. The main outcome of interest was a constant score at 2 years post-op, and secondary outcomes of interest were Oxford shoulder scores, as well as radiographic measures. And again, follow-up at 2 years. So what did they find? So patients in the reverse arthroplasty group had a statistically significant higher mean constant score versus plate fixation, and that's 68 versus 68 versus 54. Stratified by OTA classification, type C2 proximal humeral fracture showed a similar constant score trend, significantly favoring the reverse shoulder arthroplasty group. Type B2 proximal humeral fractures also showed a higher constant score in the reverse arthroplasty group, but the mean difference was not statistically significant between groups with respect to the B2. So discussion.
All right, so we got a question coming at us from Mahdi Al-Shafar, who's wondering how often or how do you, I should start with use a scope for greater tuberosity fractures, and if you do, does the size of the fracture or comminution matter? Have you ever busted a scope out for one of these, Moin, or?
I have. If it's a small fragment, it's very easy to just incorporate it like a rotator cuff repair. I think when you get into very large GT fractures, I think they're better managed in an open fashion, screws and plates.
Do you have a size cutoff, or like how do you make that decision? Are you using an MRI, CT, just something you're measuring off the X-ray, or?
I usually do get a CT scan just to better see the bone, and I think probably anything less than a centimeter, at least in my experience, has been easily done with a scope. But I think once you get bigger than that, it becomes a little bit more difficult.
Does the sig comminution or even the quality of bone matter? And maybe related to that, is there like an age where you'd consider maybe even non-op or a different treatment modality for these patients?
Yeah, I mean, if it's minimally displaced in an elderly patient, I would definitely consider more non-operative. Usually a younger, more active patient, and if there is significant displacement, like more than 0.5 millimeters to a centimeter, then I would be a little bit more aggressive with fixing it.
Okay, well, I think, I'm someone who's not as adept with the scope as my colleague here, and I'm very much an open trauma surgeon. So I think, in my hands, I would try to refer these ones on to my colleagues who are better equipped to deal with them. But sometimes I do find myself in a situation where maybe it's because a persistently dislocated shoulder is coming in and needing urgent or emergent management. We're taking these patients to the OR, and in that situation, I open these up and do, I'd say, the trauma person's rotator cuff repair, where I usually capture the rotator cuff and defunction it through a bony bed and tie it over a plate. But I think, we have in a situation that's not as urgent or emergent, or you're not open, I think a scope is an excellent tool for these. I'm just going to actually stop sharing my slides, and then I'm going to maybe open up the floor for more of a interactive format. And again, I encourage you to turn on your videos and join our chat as a group here. And you're more than welcome to ask questions around upper or any upper extremity trauma topic we mentioned tonight, or maybe even something we didn't get a chance to discuss. But getting back to humerus fractures, I think it's always and maybe the first paper that we brought up looking at nailing versus plating for these injuries. A lot of discussion is often had around shoulder outcomes and potentially superior shoulder outcomes for or superior pain outcomes and less shoulder pain or if compared to IM nailing. When do you ever get like these patients showing up in your clinic with rotator cuff tears or rotator cuff issues following nailing, or have you seen that?
I have not seen it yet, actually, and maybe it's just because nails are not as commonly used. But yeah, I haven't seen any patients yet who've had that.
Yeah, I think there's a lot of attention on it. I think when we do use it as the treatment option, we've gotten better at trying to avoid the footprint, or if we're going to go through in a more controlled manner, or we're making a formal longitudinal incision and opening up to find a start point, and protecting the cuff a bit more. But I think as we've seen these studies in the past look at the same question, usually plating comes out on top for that, is one of the main reasons. I think we're going to be seeing more of this, and that's why I wanted to highlight the Canadian Trauma Society RCT as well, because that's really, I'd say, the best evidence around these types of fractures now, and it's a good size in terms of an RCT, and something that I think we can trust is getting at the truth. And there is really an early benefit to treating these patients operatively compared to non-operatively. And for some patients, you don't want to make a big incision to put a plate in there. I think we're going to be seeing nailing used more frequently. So maybe some of these rotator cuff issues may be presenting themselves or finding your doorstep soon.
Yeah.
What about, if anybody else has questions, welcome them. And then we have a poll coming out to the audience here to see how there's this, what your experience is with respect to nailing versus plating for these injuries. And maybe if you haven't seen one option too frequently, or maybe haven't seen these fixed too frequently, I think that's going to be shifting soon. Let's maybe switch.
To see what the prevalence is of nails, just amongst this audience.
Yeah, it looks like at least 50% of the audience is broken out a nail for these fractures, and it'll certainly be. I think we'll be seeing that jump back and forth as these options hit the OR floor. Now I'm seeing a few questions around proximal humor, so maybe we'll shift gears a little bit, and it's interesting to see arthroplasty and how it's really taken off as an option for these in the last 5 years even. And I think we have a lot more arthroplasty, shoulder arthroplasty surgeons out there than we used to, who are comfortable using this acutely. And we have a question from Michael Carroll, who it's great to see joining our discussion here, asking what types of arthroplasty systems are people using for proximal humerus fractures, cemented, uncemented, and maybe some options there. So Moin, what do you go to for these?
Yeah, I'm using a cemented fracture type stem, and most companies have a type of stem that is suitable for that. Usually they have some holes around the GT where you can tie the GT down, but that's my go-to.
Yeah, and it'd be great to hear any of the other attendees and what kind of systems you guys are using. Maybe we can have a poll on how many use a cemented versus uncemented system when using arthroplasty for trauma, because it's a different patient than the elective population, and the bone quality is different, and there are additional considerations like you mentioned with having to tie down the rotator cuff. And do you think the systems that we have out there today, do you think they adequately address these issues, or is there anything missing, say when you're treating a fracture patient with an arthroplasty? Is there something more you wish you had, or do you think the systems are getting out what we need?
Yeah, I mean, sometimes it's difficult to judge the height, especially if you have a lot of comminution, soft bone. So there's some systems that allow you to kind of lock into the humerus and then kind of judge that. But otherwise, you're sort of cementing it in and then reducing it and hoping you kind of got it right.
Well, it's, I think we've had to really shift gears in thinking about the trauma patients and how, arthroplasty is options, but, from the hips and knees and shoulders and elbows, and all the systems have had to adapt. And I just want to kind of go back to, looking at how we're going to make these decisions. And is there anything when you're seeing these patients preoperatively that you're using to help you make a decision and who's going to get fixation versus arthroplasty?
Yeah, I think it factors that are going to predispose them to poor outcomes, like if the head is significantly displaced or in their axilla or something like that, those are for sure looking at arthroplasty. There's significant step deformities in the humeral head. I think those patients don't usually do very well. If it's significantly displaced as well. Those are some of the things that I'm looking at.
Yeah, I think, a lot of the traditional criteria, we talk about the head split, the medial displacement, the 3 and 4 part fractures. I think an interesting one I heard of more recently is looking at the quality and the volume of cancellous bone immediately below the articular surface as well. And it's kind of, if you think about these fractures, sometimes you have just a shell of articular surface and there's no real cancellous bone that's subarticular compared to, some patients who might have more bone to potentially put fixation or potentially have to heal. Recently I've heard that as an option. I think as we're using operative management more frequently and having to make this decision that we're having to go through CTs and trying to, and other patient characteristics to really help us make this decision. It'd be interesting to hear if the audience, through the chat or through discussion, what kind of factors are you guys using to make a decision outside of the traditional things we hear about, like head split or medial displacement? And sort of as we're having people, having the group think that or soak that in and think about it, we can maybe just, have a discussion relative to the proximal humerus, humeral shaft, distal radius, and what is, how do you bring out the discussion of what factors you're using to treat that patient and make a treatment decision in fracture clinic when these patients are coming to you and talking about, early versus late goals, pain, avoiding secondary operations? What factors do you think patients care about, and what do you need? What should we be using as our counseling with these patients?
Yeah, I think a lot of it, is very individualized for the patient. So elderly patients that are maybe medically compromised or at risk, I'm, more likely to treat them conservatively, and I think they usually do pretty well. And then, some of the factors that you mentioned, and as well, I'd be more inclined to treat them surgically with a shoulder arthroplasty earlier. But oftentimes, I think it's very reasonable to put them in a sling and see how things go after a week or so. Sometimes things settle a little bit, and the alignment improves a lot. So I've done that as well. I don't know what your experience has been with that.
Yeah, I think, it all really starts with that discussion and letting the patient know that if one treatment option isn't working, we still have options. And I think that is probably one of the most important parts of the discussions I have with patients when talking about operative versus non-operative or different treatment options. And as we've just seen, the different things are prioritized in each study, and we have evidence across different outcomes, but all of those outcomes might not be important to the patient sitting in front of you. So, when I initially discussed this, maybe there's some benefits early versus late of one option versus the other. I combine that with what functional goals the patient has and how quickly they're trying to get back into action. And and if one treatment option isn't working, we let the patients know that they can switch gears and maybe have an arthroplasty later if, say, non-operative treatment didn't work initially for their proximal humerus fracture, and at 1 and 2 years, hopefully we can get them out to where they want to be. So just looking through the poll results, we were talking about proximal humerus fractures and treatment options for arthroplasty, and most of the group here is using cemented, and I think that's kind of in line with what we were discussing, to help deal with the bone quality for these patients. To kind of bring it back to something the audience might be more familiar with say like hemiarthroplasties for hip fractures. It's been hard to displace the smooth, polished, cemented stems, and I'm not sure, it's gonna be hard to displace a cemented option for proximal humerus as well. Would you ever consider, like, say, one of the short stems, or is it the stem length would come into play for you for these options here, Moin?
Yeah, I think, with the proximal humerus fracture, obviously the proximal humerus is significantly impacted, and I think it's very difficult to get any reasonable fixation with a short stem or a proximally coated stem, and that's why I think it's much more reliable to just go with a longer cemented stem.
Do you worry about any peri-prosthetic issues, like, say, fractures around the stem, or that's not really a concern for you with these patients?
It hasn't been, at least in my experience.
Yeah, I think that's something we again discuss a little bit more now in lower extremity injuries when we talk about even distal femur replacements for distal femur fractures, and seeing some fractures around a stiff stem, and around the upper extremity, we don't worry about stresses to that level. We more want fixation for stability. So I think as we're seeing them applied more frequently, we might see some fine tuning of the different options out there. Just getting some more comments here through the chat, and another great comment and great comment from Stuart Proper, looking at biologic age, or commenting on biologic age and the ability to achieve stable fixation, allow for early motion, and which is essential, I think, as a treatment goal. But most elderly patients will cope better when they can actually use their limb for their daily functional demands. And the initial 3-month advantage, is that what we want to seek, or should we be focusing on making sure that same functional improvement is seen in 5 years? Should we tease that out? What should we be emphasizing and hanging our hat on? That early outcome? Should we ensure that early outcome is seen at 5 years, or even if the outcomes are different, early versus late, should those later outcomes be emphasized for certain patients? And Moin, as you kind of apply maybe some of this from the sports realm, if there's two treatment options and one is drastically different with respect to early versus late benefit, do you think patients understand that late benefit well enough to de-emphasize maybe some importance placed on early benefit, or do you think everybody sort of sees in the now or lives in the now?
Yeah, I know. I think patients do understand that, and I think that's why, with evidence-based medicine, it's not just about looking at the study and the outcomes. It's everything is really individualized for that patient. So a particular patient may really value the early outcomes and want to go ahead with the surgery and undergo that risk, whereas another patient may not have the same values. And so tailoring your experience, your skills, the evidence with the patient's desires is what evidence-based medicine really is. And so I think that's a great comment by Dr. Proper.
Yeah, I think, and I think that's an excellent note to kind of move to conclude the session. I think, we're cognizant of there being more OE sessions to get to tonight. So we want to leave everybody plenty of time to soak in what you heard here and then get ready for the next event. So, we more than welcome any more questions in the chat, or you can even reach out and contact us after. But with that note, I think we have to consider that we have the best evidence, but we also need to incorporate that with the best discussion and the values of the patient, as well as what the surgeon can provide for them in their resource setting. So again, thanks again for tuning in to our chats around some of the latest and greatest evidence around upper extremity trauma, and encourage you to join in the last few events for the OE World Tour. Thanks again, everybody.